So today's conversation is with Lucas Bohlen, an osteopath from the Osteopathy School of Hamburg. Lucas is involved in research and education, and we dive into some juicy topics around what is actually going on when a patient and therapist interact during a touch therapy session. Lucas and I base our conversation around a recent paper that he authored on chronic pain and mental health. I hope you find what Lucas has to share interesting, and please remember to subscribe to the Inner Sense channel for more of this type of video. Thank you very much. Good morning, Lucas. Thank you very much for joining me.
Good morning, Ian. Thanks. It's a pleasure to be here.
And I'm so excited about what we're going to talk about today, because it comes to the very core of what I spend most of my working week doing, which is hands-on therapy with people and more broadly health coaching. So the approach which we're going to discuss today is close to my heart. Perhaps we can start with hearing a little bit about your background and how you ended up working at the Osteopathy School of Hamburg. And as I understand from listening to the Active Inference interview, you're also studying in London. Is that correct?
That's correct, yes. So my name is Lucas Bohlen, and I'm an osteopath working primarily in research and education at the Osteopathy School in Hamburg. And I finished my master's degree in osteopathy in 2019, started working at the Osteopathy School shortly after. So I've been working part-time in research and education since 2019. And then I started studying psychology and neuroscience of mental health at King's College London in January 2021. So I've been studying mental health for 1 year now. And this is a master's degree as well. So I think this is basically my background, osteopathy and mental health, which is also the title of the paper we want to talk about. So I think it's quite an interesting journey.
And what made you want to do, so after completing osteopathy, what made you want to specialize and do a master's degree? What drove that?
Yeah. So in essence, it was my master's thesis in osteopathy. So my first master in osteopathy was concerned with the facial feedback hypothesis, which is also related to embodied cognition. So the basic premise is that emotions are not only expressed in the facial muscles, but also the facial muscles produce some afferent proprioceptive feedback to inform the emotion as well. So it's like kind of a feedback loop. And I was interested in how to manipulate facial muscles and therefore affect some emotions. And this was previously done with Botox injections. And I thought osteopathy is non-invasive, maybe a better approach to do so. And this was my master's thesis. So I got engaged with embodied cognition during this process. And interoception was introduced to me, I think, through Francesco Cerretelli, who is a co-author on our paper. And he proposed an interoceptive paradigm for osteopathy, arguing that osteopathy primarily works through the interoceptive system. And so I brought embodied cognition and interoceptive theories together and drafted a little text conceptualizing osteopathy in this regard, and sent it to Francesco and George Estefas, another co-author on this paper. And they got back to me, invited me to a little research group of osteopaths who try to reconceptualize osteopathy under the active inference framework. So from there on, they sent me, I think, 200 papers, and I started reading, and was then engaged with the predictive coding account and the free energy principle and so on. So I think this is the journey into the different fields that are represented in the article. So we have osteopathy, interception, predictive coding, and embodiment, so embodied cognition, which are all, I think, brought together in the article to provide a background on what we are proposing.
So many fascinating things you've hinted at there, and I could delve into this idea of facial expressions and the effect of them on our mental health. That could be maybe a whole conversation on itself. But for now, for many of the people watching this may not be familiar with osteopathy. So can you please just explain the key components of osteopathic approach of healthcare and how it differs from other approaches? So, for example, in your paper, I saw that osteopathy aims to find health rather than disease, or aims to look for the causes underlying a condition rather than just the symptoms. So maybe we can start there, please.
Yeah, sure. So it is actually a quite difficult task to define osteopathy because it is quite comprehensive. That there are many different perspectives to it. But I think it is good to start with saying that osteopathy is a person-centered form of healthcare. So it tries to individualize care for their patients, and it does so by using both hands-on approaches, so manual touch approaches, like touch and manipulation, and it also uses patient management approaches, which includes patient education, psychological support, self-management solutions, and lifestyle advices. And so these kind of approaches are combined in practice, and they are guided by some models of care, osteopathic models of care, and some principles, of which you have mentioned, I think, 2 of them. So so the approach, in essence, tries to enhance the structure and function of a person, and there through its the well-being of the person. But I also like to define osteopathy as enhancing the knowledge and perception of health for the patient, because I think these are 2 main points that osteopathy tries to achieve with a patient.
So for them to understand themselves better, or understand their body better, is
Right.
that what you mean by that?
Yes, that's what I mean. So understanding it, but also feeling it. So I think the perception is quite an important part of osteopathic practice, which is, I think, transmitted through touch in essence. Yeah. So
okay, that's we'll lead on to that when we talk about interception and errors and prediction errors and so on.
Yeah.
Okay, so it's because here in the UK, I think many people, if they think of osteopathy, will associate it with these high velocity thrusts and the adjustments to the spine. But from what I'm hearing from you is that there's a bigger picture. It's about all of these other lifestyle factors that influence health, and maybe even emotional factors as well.
Yes. So I know that in the UK, the osteopathic profession is regulated, which it isn't in most other European countries. And therefore it is quite focused on the musculoskeletal system, because if you regulate a profession, you have to define what the aims are. But there are not only manipulation approaches, but also touch-based approaches. And another interesting factor is that osteopathy doesn't solely target the musculoskeletal system, but also the visceral system and the craniosacral system. So there are a few points that need to be combined for an holistic osteopathic treatment, not only the high-velocity, low-amplitude manipulation treatment, but this could be quite helpful as well. And I think guiding these approaches are the osteopathic models, and you've hinted to the biopsychosocial model, I think, earlier. This is part of the osteopathic models as well, combined with the biomechanical model, which is in essence manipulation. But also we have neurological model, metabolic model, respiratory, circulatory model, and so on. And then, of course, we have some guiding principles from our founders early on, which involves that body, mind, and spirit are a dynamic unit, but also that the body has self-regulatory processes and is self-healing. So osteopaths themselves don't see them as healers in the form that they bring health to a patient, but they try to support the self-healing abilities of the patient, which is, I think, another philosophical perspective. And we also view structure and function as interrelated. So this is another basic principle. Finding health and treating the cause rather than the symptom are also quite frequently cited principles of osteopathy, but they are also discussed within the profession because they are it is not well defined how to scientifically evaluate these principles and if they are still relevant today in the 21st century. But therefore it is quite difficult to define osteopathy. But I think all of this needs to be brought together to present a picture.
Okay, so that's a really lovely background, and hopefully, that with that picture of a holistic approach and lots of different factors that can influence a person's health, and lots of different entry points for a practitioner, or things for a practitioner to consider when they're interacting with their patient or their client. So what led you and your colleagues to publish this paper? The title is Osteopathy and Mental Health, an Embodied, Predictive and Interoceptive Framework. That's the title. So the framework, can you just run through the basic premise of the framework, please?
Sure. So I think before we start talking about the framework, we have to define some of the basic principles or the underlying principles, if that's okay with you. So
yeah, certainly.
Like Inactivism and predictive coding, to provide a little background on these topics.
Mm-hmm. Yep. Let's start with Inactivism, because that's, until I read your paper, I hadn't really, I've heard the term, but not really heard it mentioned in this way.
Yeah. Okay. Perfect. So Inactivism, in essence, proposes that cognition emerges from the dynamic interaction of the organism and the environment, so brain, body, and environment. And it is based on the 5 or 4 E's, which means that cognition is an embodied, embedded, enacted, extended, but also ecological process of sense making. And sense making in this instance means an evaluative interaction between the organism and the environment. So what do all these 5 E's mean? So they can be related to cognition, but also to pain. So Peter Stilwell is an author who proposed that these kind of enactive perspectives can be applied to pain as well. And these papers are highly recommendable. So embodied means that cognition is enabled through, but also constrained by the non-neural body. And embedded means that cognition depends on the environmental context. So an organism is always situated within an environment, and cognition thus depends on the environmental interaction. And it is also enacted, which means that cognition is basically for action. It depends on the interaction between environment and organism. And it is extended. So cognition extends beyond brain and body into the environment. The most notable example is Carl Friston proposing that your smartphone is an extension of your cognition, because you don't know maybe your fiance's phone number, but you can call her through your phone. So it's kind of an extended process. And it is also ecological, meaning that cognition depends on environmental affordances for action. So these are the basic 5 E's you can apply to cognition and also pain. And this.
So sorry, just to interrupt. The first one, the first E, what was that again?
Embodied.
Embodied. Okay, so for some people that might be a bit of a surprise, because we think of the mind somehow being independent of the body. And the word you use there, that the body can constrain our thinking. In some ways that seems really obvious. So when when I've got a cold and there's loads of, my immune system's flared up, then my thinking maybe is constrained in some way. It's limited. Or if I'm in a food coma after a big Sunday roast dinner, then my body is very busy digesting food, and I've got a bit of brain fog. And likewise, if I've just done an exercise or a workout and, everything's rushing and racing and I have all these amazing thoughts. So it kind of seems obvious in one sense, but I think more broadly in our culture, the way that we think about cognition, we almost think, we tend to think it's independent of anything below the neck. It's just, this brain power that works on its own. So was this something before you wrote the paper that you were aware of, or has it deepened your understanding of how your mind works in your own life? Would you say?
Sure. So basically, it is a new perspective. Embodied cognition is a new perspective to the cognitive sciences, but it is also it opposes the dualistic thinking. So the thinking that we have a mind that might be separate from the body, but you have talked about it earlier. So the brain is also part of the body, and it is biological in essence. And there are quite philosophical debates about if there is some kind of dualistic separation between some kind of mind stuff that is not biological and the biological body, or if this is all the same and the brain is biological and therefore the mind also has a biological basis. I think an interesting book that I've read is from Anil Seth on consciousness and
being you.
Yeah, sure. Yeah,
excellent. Yes.
Yeah, I think this outlines a lot the discussions and separations between body and mind that embodied cognition kind of calls against.
Yeah, I love one of the quotes in his book that he cites often. It's I think it's all perceptions are controlled hallucinations that happen with, through, and because of a living body. That covers Inactivism.
Yeah, I think that covers Inactivism. Plus, there is also, we have to apply these perspectives to physical and mental health conditions to make sense of them. So it says that, for example, pain and depression are associated with an altered interaction of the organism with its environment through its embodiment. So this is also the true unity we can think of in activism. Yeah.
And that's sort of matching what is happening in the understanding of genetics and epigenetics as well, that it's maybe a fluid relationship between the environment and our genome.
Yeah, and it makes sense. As I said, I've studied mental health at the moment at King's College. So there is not only the cognitive and emotional factors, but also the environmental factors and the genetic factors and so on. So the interplay of all of this is basically a basic premise that is better explained, I think, in Inactivism than in previous accounts of cognition and pain.
Thank you for that. Really changed the way that I viewed how our brain works and the role of the brain even. So what's predictive coding?
Yeah, and it changed my view as well. So I think the basic premise is that our brain is not a stimulus response machine, but an inference machine. And this is predictive coding. So it argues that the brain has a model of its world or our world, and this is based on past experiences. So this model is constantly generating predictions about the sensory information that we might encounter. And these predictions are then actually compared to the actual interceptive or proprioceptive or exteroceptive input that we are getting through our senses. And indeed, only the information that mismatches with the prediction is carried forward within the cortical hierarchy. So the model is only updated if prediction error, so a mismatch between the prediction and the actual input occurs. So this also basically means that the top-down predictions constantly explain away bottom-up sensory information, and that we are constantly predicting things and perceiving more things that we predict than actually happen. And I think this is a basic premise of predictive coding, which is closely related to active and perceptual inference, which is an important next step, because if we have a prediction error, so the mismatch between the predicted and actual information, then these prediction errors must be minimized by the organism. And it can minimize these errors by either perceptual inference or active inference. And perceptual inference means then that the generative model is revised based on the prediction errors, which means that the information that is actually coming revises our model of the world, which is something we should be looking forward to. And on the other hand, active inference is an interesting principle, arguing that the organism also acts on the world to generate these states that the generative model has predicted. So this is kind of a self-fulfilling prophecy in which we try to eliminate the errors by not eliminating them in essence, and confirming our prediction. Yeah,
If I understand it correctly, then all of this predictive nature of our actions and the model that we have of the world, that's all in service of keeping us alive, basically. So trying to maintain homeostasis, and this idea of that we predict stuff and act on it in order to make it a self-fulfilling prophecy. Would you say that that's how indeed we maybe do something simple like maintain a body temperature at 37 degrees C? So, we're constantly, either consciously or subconsciously, taking actions which maintain our temperature rather than it just being a passive process.
Yeah. So I lost you for a second there, but I think you're hinting on allostasis and homeostasis and the. Yeah, sure. So homeostasis is the basic principle that we keep our values at a constant level, so that body temperature is always at the constant temperature. But allostasis says that we need to predict future needs. So therefore, we have to kind of go into the future and predict things that might happen and that are important to stabilize our homeostasis also in the future. So I'm not sure if I got your whole question, because the internet was unstable there.
Okay, yes. So it was really just trying to bring that back to something basic that keeps us alive. So something like body temperature or the need to eat. So from what I understand, this difference between perceptual, updating the perceptual model that we have of the world versus taking an action to as a self-fulfilling prophecy to reinforce the model. So it's like we've got two choices. We kind of accept that our judgments that the body or the mind has made are wrong, and we update that, or we act to reinforce it.
Sure.
Again, are there any sort of insights you've had from your own life after contemplating this idea of predictive coding or active inference, that you've seen that play out in your own life?
Yes, it helped me understand a little bit. So these processes, is important to emphasize that these processes are both conscious and non-conscious, and mostly non-conscious. So this is something our nervous system does on a moment-to-moment basis. But I think this knowledge helped me better understand my own health in some kind of ways. I have an example, if you like. I had a few years back on New Year's Eve, I had a little panic attack in the train while riding home. So in the later weeks, when I confronted that fear by riding the train excessively, it helped me a lot to understand that my brain predicts fear to happen in the train based on my past experiences. And it helped me a lot that my brain likely initiates autonomic activity, like an increased heart rate, to confirm this prediction. And that if I'm sitting in the train and my heart starts to pound, that this is likely the prediction of my brain, nothing serious to be worried about. So I think this kind of calmed me down and therefore led to me being exposed to the environment and updating and revising my model, my fear of the train, which was not rational, but an anxiety aspect. So I think today I can ride the train without problems. And the main thing was for me breathing. So kind of controlling my autonomic nervous system and my breathing and meditation and so on, which kind of helped me. But I think the basic idea behind the whole predictive coding account is what helped me. So understanding what happens.
So you kind of gave yourself a sort of exposure therapy by going back onto the train. Right. And it's, I think the old phrase, if you fall off a horse, the best thing to do is to get straight back on.
Yeah, sure.
However, having that knowledge of the autonomic nervous system and recognizing that the feelings that arise may just be a prediction rather than a caused by the train or the situation or the environment could be a breakthrough for some people. I think, because it often feels like these reactions happen so quick that it feels like they're caused by something else, rather than being a prediction of something.
Yeah, and the same thing goes for pain conditions. For example, in chronic pain conditions, people often have fear of movement, not because they really experience the pain, but because they expect the pain to happen if they move. So I think this knowledge does not only help with to understand your mental health conditions, but also your physical health conditions. And I think this is the essence of the paper, to provide another perspective to this.
Yeah. And maybe we'll talk about this in a moment. We've got another one of the definitions to work through, I think. But I'm really fascinated on what you said about this idea of some of these things operating at an unconscious level and some of them at a conscious level, and what the how much movement there can be between those two things. Is it possible for some things to go from being conscious to unconscious habits, and likewise, can we bring things that are unconscious into our consciousness? And is that happening during therapy? So maybe we can talk about that. But first of all, enslaving autonomic reflexes. That was a term which I thought was really interesting.
Yeah.
What does that mean?
Yeah, this is a term I borrowed myself. So Seth was the first, together with Carl Friston, proposing this term in their paper about interoceptive interference. So basically it means that the bodily states are regulated by autonomic reflexes, and that these reflexes are governed by our predictions. So that, for example, as I've said, I think earlier, that raising the heartbeat in response to a perceived threat would be kind of an interoceptive inference thing to do, because our prediction predicts a threat and therefore adjusts our autonomic nervous system to kind of reinforce this prediction. Yeah, and I think a notable thing here is that both pain and depression are likely linked to interoception, and therefore failures of interoceptive inference are a main thing we have to consider here. And this is, I think, very simply the idea of enslaving autonomic reflexes as kind of a way of using active inference to make the predictions come true.
We've covered inactivism, predictive coding, and enslaving autonomic reflexes. Yeah. So there's this idea that our cognition, our thought processes, our mental functions are tightly coupled to our body and our environment and so on. That's one. Then the second one is predictive coding, that we're not just sensing and processing and reacting, but our bodies are constantly anticipating or guessing what's going on in the world and trying to act in order to help us with these predictions. And then finally, that these predictions will enslave autonomic reflexes. So these sort of built-in mechanisms in our body to regulate our physiology, that the predictive model will use those to try and help us. Is that correct?
A great summary. Aye.
Good. So with that in mind, what's the framework that is being proposed for osteopathy and mental health?
Yeah. So this is really the core of the paper. So we have covered a little bit of the background that I'm also outlining in the paper, and this all leads to the framework that we are proposing. And it basically tries to reason, but also to provide some future directions for research on the putative effects of osteopathy on mental health, particularly in patients with persistent physical symptoms. So to imagine this, you can imagine a patient with chronic pain and comorbid depression as an example, which is quite frequent in osteopathic practice to engage with patients having comorbid conditions. And these patients likely predict physical and mental states that are also associated with their pain and their depression to be the likely cause of uncertain information. So this is kind of their model, their prediction that is constantly going on. And
so it's a bit like a vicious cycle that they've got caught in with the experience of depression feeding the experience of pain, and the experience of pain feeding the depression, and it's kind of snowballing in some way. Is that right?
Yes, this is right, because this plays onto the comorbid aspect of it, but it is also that if you only take pain, for example, that pain is predicted. So that, for example, a patient with chronic pain is likely to predict sensory information like a touch on the belly as painful if he associates this touch. Another person without chronic pain wouldn't expect this touch to be painful, but instead quite pleasant, for example. So the generative model of these patients is likely to predict even unharmful stimuli as being painful, for example. So this is a basic assumption about the patients and the people with chronic pain and depression that is kind of supported by the literature. And if you now imagine in an osteopathic treatment session, the only thing we do is provide sensory information and sensory input to the system, for example, by talking, but this is exteroceptive, but mainly by touch and manipulation, which is interoceptive. So we likely, we produce interoceptive information and generate this input for the patient. And this input is likely not painful and likely not associated with negative emotion, but quite pleasant. And therefore, it is likely that the patient has a surprising mismatch in information because the prediction of pain is not confirmed through the actual touch in osteopathic practice. This likely generates a prediction error. So this error needs to be minimized. And we have talked about it earlier. Minimization is either perceptual or active inference. So what we propose is that in chronic pain and depression, there's a high precision that is afforded to the belief and the prior, so the generative model, and not to the actual interoceptive information, which is afforded less precision. And therefore, the first step would be to engage active inference processes. And active inference processes then produce the symptoms or try to resemble the symptoms through autonomic nervous system activity. And this is what we've talked about earlier by engaging the autonomic reflex arcs. And then it is likely that the patient generates autonomic nervous system activity that kind of resembles the predicted symptoms, but this is not in line with the therapeutic setting and also the therapeutic alliance. So in a treatment session, a patient might not really expect to feel very bad or start crying, but instead they likely expect health promotion. And this is the environmental context that I think is not matching, therefore leading to the second step, which is perceptual interference. And I think that this is the actual thing that we are trying to support in osteopathic practice is perceptual inference, which means that we likely update the model based on the actual sensory information so that future predictions are revised. And this kind of framework we have applied to osteopathic treatment and try to also apply it to the real touch intervention. So from experience, what I have experienced often and what drove me to this paper was that if I treat patients, they often react with an autonomic and also emotional response. Mm-hmm. And I think the best answer I found in the literature before was some kind of fascia holds memory, and this memory, if it was released, might be also releasing emotions. And I was not really a big fan of these ideas because they were not really grounded in the best literature, I think. So what we propose is that if we touch a patient and he's reacting emotionally, also likely with a sympathetic activity of the nervous system, not parasympathetic, then this is active inference. So the patient is predicting that something emotional or painful is happening, and therefore engages the autonomic nervous system to make these predictions come true. And this is kind of, if you have a treatment, this is the first reaction that might mostly occurs, followed then by more parasympathetic activation and more emotional calmness. And I think this is then the perceptual inference, the patient revising their model based on the actual input that we are providing. And I think this is, in short, in a nutshell, our framework.
Okay, that's great. So with that example you gave of, someone being touched on the stomach, who has persistent pain, and they may experience that as being very distressing compared to somebody who doesn't have persistent pain. So is what you're saying that in a therapeutic setting compared to a non-therapeutic setting, if that person was being touched in that certain way, they may, the active inference part is that their body will create the experience of pain or distress in some way to and maybe try and resist against the touch or the what they're experiencing, which will further reinforce the existing model they've got. However, when they're coming for a treatment or a therapy session, they kind of somehow, there's a little bit more trust there that they're going to receive something therapeutic. So they, that's where the error comes in, because they're getting a stimulus which in another setting they would feel threatened by, but now this time they kind of feel that they're safe. So that's when the potential for the model to be updated arises. Is that correct?
Yes. I think what you're describing is the transition from active to perceptual inference. But I think at the beginning, the patient is likely expecting painful or negative emotion to be the cause of unknown or uncertain information. So someone who hasn't got persistent pain might not expect some sensations that that are uncertain to be painful, but instead surprising. And I think this is the start of the active inference process. Yeah.
So before the transition stage, there's another step before that. Yeah. Okay. That's very important. Okay. So can you give maybe another sort of practical example of how expected symptoms may confirm a prediction? So you've talked about the autonomic nervous system, but are there any other examples of, maybe not in the therapy room, but outside in everyday life, that a person's pain or depression may be perpetuated through active inference?
Yeah. So I think if it's okay, I would start with an example of pain, because this is something we are quite engaged with as osteopaths. So the basic premise is that people with pain are predicting painful sensations, even if there is harmless stimulation. And you can, for example, imagine a patient with chronic back pain, and this patient is likely to predict that movement of the back will be painful. This is kind of the basic expectation of their model of the world. So
they're thinking, last time I bent forward to tie my shoelaces, it hurt. So this time it's going to hurt as well.
Yes, a little bit. I think it's connected, but I'm not sure, to fear of movement. And this is what you're describing, the fear of movement, because they predict pain to happen in this instance of moving. But a basic thing is that often patients then contract their spinal muscles to kind of prevent pain during movement, but it does the opposite. So it restricts movement. It likely causes also pain, which then reinforces the prediction again. So if you start loosening these muscles, the movement might not even hurt, but by contracting the muscles, so an action of the sensory motor system, which is often in response to exteroceptive stimulation, as the autonomic nervous system activity is likely to be a response to interoceptive stimulation. So they contract these muscles, therefore can't really move well and produce pain as well, which then reinforces the model that you shouldn't bend over or you shouldn't move. And we know from experience that chronic pain patients, movement is one of the best things you can do, because but only if there is not a biological basis that movement would deteriorate the symptoms. So if there's some kind of injury and movement should be reduced, then this is totally fine. But in chronic patients, often there's not a biological basis for the pain, not an injury, and therefore movement should be promoted.
Mhm. So when you say biological basis, you sort of set tissue injury, for example, inflammation or structural damage. So that's not, if you can rule that out and there's still pain, then it's possible that there's some kind of predictive nature to the persistent pain.
Yeah, I think it is important to stress that pain happens at multiple levels. So there's not only the biological basis, but also social aspects and psychological aspects to pain. And if you go a step further, even from the inactive perspectives, the interaction with the environment. So it is hard to define pain, and I think we will learn more about in the next 10 years and 20 years. But I think it's important to stress that there is not one patient with only biological pain and one patient with only social pain. It is always a mixture of all of these facets. But I think if there's not a tissue injury that gets worse while moving, I think movement is something that we can wholeheartedly recommend to the patient. And I think it demonstrates well the predictive process that often happens in patients with chronic pain. And I think maybe you have had pain for a longer time, then you know that moving is something we try to avoid, even though we shouldn't avoid it.
Yeah, I've just finished listening to a book called on Audible called The Painful Truth by Monty Lymon. I don't know if you've come across that.
No, I haven't.
It's excellent. He's maybe I'll send a link, but yeah, he actually includes a section, or he's basing it loosely around expectation, but it's not a self-help book. It's more of an update on where the science is at with pain. But yeah, that's a lot of the things you're talking about. He's included in that.
Yeah. Brilliant. I would recommend, if you're interested in pain, to listen to Peter Stilwell and Sabrina Cornix. They are implementing the inactive approach to pain, and it's brilliant. Their work would be a really, really good read for you, I think.
So are they academics or practitioners?
Yes.
Or yeah.
Yes, Peter Stilwell is a chiropractor who's primarily involved with research, and Sabrina Cornix is a philosopher from Germany who's involved in philosophy of pain. So they work together on these concepts.
Great. Yeah, I'll look that up. Thank you. So that was an example with pain. How about with depression, and how could that possibly be a self-fulfilling prophecy? And I'd like to say here that it's important to distinguish between conscious and unconscious patterns operating, and saying that people are making things up or imagining things. Sometimes I think that it can seem like that's what's being implied, but actually it's quite the opposite. What we're saying here is very real mechanisms maybe operating that we want to shed light on.
Yeah, and this is important. We're talking about mechanisms of the nervous system underlying these processes. So it is, I think, most frequently unconscious. It's the way we think the nervous system might work, the mechanisms that are involved. So it's not to blame anyone. This is exactly the opposite. So depression, there is an interesting paper by Tobias Kube, also from Germany, who proposed a predictive coding perspective to depression. And he's arguing in a nutshell that people have negative prior beliefs about situations that are not updated when they are confronted with disconfirming information. So the primary thing is that positive information is disregarded or negatively reappraised. And the basic idea is, for example, that a person with depression may expect some negative emotions in a certain context. So this is kind of an expectation of the generative model. It must not be conscious. It can be totally unconscious. And therefore, the autonomic nervous system, for example, is engaged to generate a parasympathetic activity, for example, which kind of is closely related to fatigue, which is a main symptom of the body in depression. And therefore, maybe the patient lies down and then re-experiences more negative emotion because they are not engaged with the world, but try to escape this world, and therefore reinforce their model of the world. Yes, this could be an example of how these predictive processes play out. I would recommend the literature from Feldman, Lisa Feldman, on depression and allostasis. It's very, very interesting concepts that she's proposing there, to get a little bit more into depth with these kind of ideas.
Mm-hmm. Yeah, thank you. I'm a big fan of Lisa Barrett's work and the way that she communicates. And yeah, I think this idea of having different preference or weighting for positive or negative expectations. Again, I would like to stress, we're not saying that people are blaming people for being negative. It's not like that. It's actually that it's almost like their nervous system has got into a habit of using or focusing on different information.
Yeah. For me, I think when I imagine these kind of things, it's like, for me, like myelization of the nervous system. So if you, I think that Oliver Sacks was the one proposing these kind of metaphor, is that if you're riding down a hill on skis or something like this, there is a road that is always used by some, and therefore after some time you can't go anywhere else but into these predefined routes in the snow. I think this is kind of a metaphor for how the nervous system works. Things we are always doing, we are destined to repeat.
Mm-hmm. Yeah. So having said that, though, it seems that the nervous system is very remoldable, and the idea of neuroplasticity. So I guess the role of a therapy like osteopathy is to guide people's hope into a direction to kind of slowly build a new road or a new path and expand the path so that it strengthens what's healing.
Perfect. Yeah, it is to revise the model and to gain some new predictions for the patients. Yeah, and it is to surprise the system. I think this is a key take-home message I had for myself while doing this research. And George Estefas pointed this out. This is something I can take home for the clinical practices. We're trying to surprise the patient in its in clinical treatment to gain some new insights for the patient and to gain some new perspectives. And often people come into practice and say, I've been treated with manipulation and I want to do more manipulation because I've done this for kind of 20 years. And then my idea is, no, that might not be the best way because it's not surprising the system. It's the opposite of that. Mm-hmm. So maybe also the kind of approaches we are selecting for treatment might be selected so that we are surprising the patient and the system.
Yeah, I like that. I actually do swap treatments with some osteopaths and other therapists, and sometimes I think that variety is very, very good. And it's when you get something that you're not expecting, that's sometimes when the biggest change occurs, or the biggest leap of in my body. So and that's what I experience with my clients as well. It's sometimes there's a guy I trained under called Noah Koresh. He does something called core fascial release, and he says that sometimes you've where the pain is, or where the problem feels like it is. Once you've worked on that area, it can be on the run. So it's almost like you have to follow it. And I think looking at that from a view of surprise, it's almost like the body, the therapist is trying to find new ways to help the body to create that change. And that's the surprising element, is that you have to follow what the therapist is following, what's happening in the patient's body, and the patient is opening themselves up to this new surprise.
Sure. And it might also be the case that releasing this tension leads to a reorganization of the organism. Therefore, the tension starts to go somewhere else because the system is reorganizing.
It's stacking itself up in a different way. Yeah, I agree. I'm aware of the time. How much time have you got?
I have some spare time, no problem.
Okay, good. So one of the things I was fascinated, or one of the papers you referenced in your study that I wanted to find out more about was an fMRI study by Serratelli et al. In 2020, which showed that osteopathic treatment increases interoceptive accuracy. So do you have any more details about that?
Yeah, sure. So I was not involved with this study. I think it was the PhD study of Francesco, who as well is a co-author on our paper. So he performed a randomized placebo-controlled trial using fMRI, and he tried to examine the impact of osteopathic manipulative treatment on brain activity. And I think he used 32 adults with chronic lower back pain. This was his sample, and they received 4 weeks of either osteopathic manipulative treatment or shame intervention, where also touch was being provided, but without a therapeutic intention, without techniques. Mm-hmm. And they performed fMRI at enrollment directly after the first treatment session and after 1 month, so after the 4th treatment. And they did these fMRI data collection while doing a task, either an interoceptive but both an interoceptive and exteroceptive awareness task. One is focused on detecting one's own heartbeat. The other one is focused on audition, so on sounds. And they found that the interoceptive accuracy of these people in the treatment group increased. So they were getting better in the heartbeat detection task. So this is the kind of behavioral outcome of the study. But more importantly, it is an fMRI study focused on brain activity. So what they found is that osteopathy produced a distinct and specific bold reaction in interoceptive areas of the brain. And they found that at T1, meaning that directly after the first session, the bilateral insula, the anterior cingulate cortex, left striatum, and the right middle frontal gyrus all increased in their bold response. But after 1 month, so at T2, they all decreased. I think the right middle frontal gyrus actually decreased at T1, but they all decreased at T2. So what this means is in chronic low back pain, patients often or are reported to have a higher baseline bold response in these areas. So therefore, there is some noise in the brain that reduces the ability to detect interoceptive information. So if the bold response decreases after osteopathic treatment, this means that the overall ability of the person to perceive interoceptive information is increased, which is also reflected by the behavioral outcomes of an increased interoceptive accuracy. So this was as a follow-up study based on a theoretical paper that Francesco published in 2016, proposing that osteopathy follows an interoceptive paradigm. And I think this is interesting work showing that osteopathy indeed likely targets the interoceptive system and works on it. But I know there are other studies that have been published to the effect of osteopathy on interoceptive accuracy. And they used different techniques and had a look if, for example, manipulation, high velocity, low amplitude, how this affects the interoceptive accuracy, and how a myofascial release technique affects the interoceptive accuracy. And I think they had some significant results from myofascial release, but not for manipulation and so on. So there's maybe more ground to investigate this. But I think the basic premise is that osteopathy is a holistic and person-centered approach. So I think Francesco kind of took the right route to investigate these effects, because he treated the patients in a free and holistic manner, and not being limited to one kind of technique.
Right.
But I think there needs to be more research in this area to conclusively state if osteopathy indeed changes interoceptive processing. But this is the idea we're putting forward here.
It's a good starting point. So with the study with the 32 people, and they were split into groups, and some of them had a authentic osteopathic touch or intervention, and the others had a sham or a mock one. What did that look like then? Was it because I guess they were in the scanner at the time, in the fMRI scanner, And then how did they administer the intervention or the sham mock intervention?
Yeah, so they did a static touch intervention, so without a therapeutic intention, just touching the patients with a stable connection and without focusing on tactile sensation. Because Francesco published a very interesting paper earlier, I think in 2017, also with fMRI, and he showed in this study that if an operator, an osteopath, touches a patient and is focused on the tactile sensation, that this indeed involves the interoceptive regions in the patient's brain, but not if the operator is focused on sensation, on auditive sensations. So the cognitive status of the operator is quite important in the way the touch is perceived by the patient on a neurological level. So these are the first results, I think, as far as I know, showing clear differences between touch with an intention and touch without an intention and without cognitive focus. So I believe that to really investigate these things, we have to provide touch, first of all, in an original and osteopathic manner, but also with a cognitive focus on these sensations. And it may also be the case that these kind of non-focused touch interventions could be used as some kind of control intervention in osteopathy, because it's very hard to generate good control conditions in osteopathy, as well as in psychotherapy, because the interventions are quite complex. And it's not like a medication where you can just put the medication in one and the not medication in the other.
That is so fascinating. And, from my own practice, what I experience, even within one session with a client, sometimes I'm more, there are times when I'm more focused on their body, and other times during the treatment, I'm less, even from, in the space of maybe 10 or 20 seconds, I can drift in and out of where my attention is. But also, I guess it's anecdotal, but I do notice the shifts in the person's body, either how they are, the palpation, what their tissue feels like, or their breathing. That seems to match what's going on with my attention. So it's really interesting to see that is being studied through fMRI. What potentially, though, it takes, for those controls, for the control of touching without the therapeutic intention, so having the therapist to have their attention elsewhere, potentially poses a problem, because maybe a therapist, this is what I'm wondering, a therapist who's so used to practicing over many years will just automatically do those things. So could it potentially be hard not to touch therapeutically and to be distracted
For sure. I think it is quite nearly impossible for osteopaths to not focus on what they're doing when they're touching a patient. We had a little bachelor's thesis here at our university where someone used non-therapeutic people to do the shame intervention. So he used, I think, they were studying, biology or something like this, and they were not involved with manual therapy, so they could touch a patient and not think about what they are doing because they don't know what they are doing. So this might be a mechanism on how to trick this. But I think the basic problem is a deeper problem. It is a problem that our trials, Francesco had outlined this in our recent discussion at the Active Inference Lab, that the basic research methods are designed for pharmacological research, and complex health interventions like psychotherapy and osteopathy might need some other methodological approaches like pragmatic trials and so on.
Yeah, I agree. Having said that, though, I can see that there is some, if we hear about co-regulation in other types of therapy and interventions, and I remember seeing some interesting studies on, I think it may have even been Lisa Feldman Barrett's, about, things that you can measure in people's bodies when they're co-regulating. So maybe heart rate sensitivity or the galvanic skin response. So, if there may be a mechanism that we can study to see what if what's being transduced between the therapist and the patient is something physical and measurable, then that may open up to seeing, is the therapist pacing for the client, and what are the key elements for that? Is it something to do with the quality of the skin from the therapist that the client's body picks up on, or is it they're picking up on the breathing or the heart rate of the therapists? You've got some interesting studies with choir people singing in choirs together, and that synchronization of heart rate and so on. So I think I agree that the pharmacological model is limiting, but I also see hope in all of these measurement devices and things that we can measure physiologically, offering some scope for experiments as well.
Yeah, you're totally right. And this is a very interesting point that I'm also considering as synchrony. So synchrony between the therapist and the patient. And this is what we are doing on the manual level. So if we are touching a patient and we are doing something with the tissues, we try to get in synchrony with the tissue and try to follow it into the direction it wants, the other direction where the restriction is. And the same thing goes for the therapeutic alliance. So we are trying to synchronize with our patient. And I think there was some interesting research on psychotherapeutic sessions where they found that synchrony of, for example, the heartbeat and so on, predicted future therapeutic success. So I think this is something we could also dive into with osteopathic research, is how well do the therapist and the patient synchronize on a biological level, which you can measure by heart rate variability, for example, and so on. And there is a lot of potential for future research.
On that, this idea of synchrony, maybe it's I have to check the semantics on this, but it's a kind of free energy minimization as well. If you've got you're reducing the chaos in the system between groups of two people or groups of organisms.
You're reducing surprise in essence. Yeah.
Reducing surprise, yeah. Fantastic. So I'm aware that we've already run over 1 hour, and we've covered there a few experiments that could be designed to scrutinize this framework. Is there anything else you'd like to say before we wrap up?
I don't think so. So the basic, when you're talking about the experience that we like to conduct based on this framework to either validate or falsify it, because it is quite important to stress this, although I should have done it in the beginning. It's a theoretical framework, so this is based on literature, but not on actual data. So we have to conduct some clinical research to further falsify or verify this framework. So the first thing that is quite obvious to do is treat patients with chronic pain and comorbid mental health problems, and have a look if osteopathy indeed increases interoceptive accuracy, if it decreases, for example, allostatic load, if it alleviates the physical and mental symptoms, and if it modulates the autonomic nervous system. And these are the basic things that that are predicted based on the framework and that have to be researched to further validate this framework. But yeah, except for that, I don't have anything to further go into. I think we have covered a lot of ground.
We have covered a lot of ground, and I really look forward to seeing how you and your team pursue this line of inquiry, because I think it could be applied to many other therapies as well. This the idea, not just osteopathy, many other, even non-touch therapies, somatic experiencing, and talk therapies that potentially involve synchrony and bringing people's attention to interoceptive signals and allowing that it's often called reprocessing, but I guess that's updating either the perceptual or active inference models.
Yeah, sure. And it is important to not exclusively apply this framework to osteopathy. It is all other manual therapies could also find a piece in this. And this paper, which we have published, is quite focused on the therapeutic touch. So it is trying to explain the touch mechanisms involved. But Francesco and George have also put forward some other papers on the therapeutic alliance, which is more focused on the communication between therapist and patient. And the research topic which our paper was published in is Inactivism and active inference in the therapeutic alliance. So if you want to have a look on this, stay tuned. There are other papers coming forward. Just one got accepted, I think, yesterday on therapeutic alliance and osteopathy in this regard. So our research group is bringing some further papers out in the next weeks. So stay tuned. There are other ideas coming forward, which are not just focused on touch, but also on communication.
Groundbreaking stuff. Thank you so much, Lucas. And I look forward to looking at some of that work and those publications.
Yes, thank you very much for the invitation. It was a pleasurable conversation.
Hope to speak again soon.
Perfect. Thanks. Bye-bye.